we try to flip on its head the paradigm of where medicine has existed, which is that for the most part, you go to a physician because they're the knowledgeable expert, and you expect them to give you an answer, right? It's like when I go to the mechanic with my engine light on, like I want them to figure it out and tell me what
Yeah.
to do. I don't want them to turn around and ask me, what would you like me to
Yeah.
do about your engine? And I think that simplistically, some people think about shared decision making in that perspective, but really you have to think first about the principles upon it's based, which is self-determination, like the idea that patients have like some agency in the decisions that they make. And when we agree that that is a goal, then defining shared decision making is much easier, because then it's about working to use the best available evidence to arrive at decisions that center around the patient's preferences, like some of their like. And so I think that, from that perspective, like it makes a lot of sense. And you would be like, well, don't we do that already? And the reality is that a lot of doctors believe they do, and many of us don't, and we certainly don't do it well. And I think that's because there's a lot of challenges in trying to operationalize that. So there's been some to try to come up with very simple models to how to operationalize that definition. And I think one of it is to think about three phrases, which is that first, you have to think about choice, like, and I think secondly, we have to think about options. And then third, we have to think about decisions, right? And so if we introduce the opportunity that patients have choice, right, which is a big deal. Like I think a lot of times patients come to me and they feel like I'm the decider. And so what do you mean that I have choice in this conversation? And part of that is maybe they don't feel like they understand the cancer that they have, and you are the expert. I think the second piece is like you have to really focus around discussing and explaining and describing the options, and that takes time. Like, and I think oftentimes we want to just jump to the solution that we think is best as the clinician, but working with the patients to talk about you do have options, and those options are centered around the last piece in terms of that discussion about the decision, and helping them to understand that that decision is not based just on one right way to do something, but rather is informed by a lot of things that are inherent to the patient. Like, so, what is their risk tolerance? What do they understand about how this is going to affect their quality of life? What do they find important, like in their lives currently and in the future? And that's going to inform a lot of the decision about whether one treatment or another is better for you. There are far too many things in medicine where there is no absolute right call clinically. And I think the perception is that once you've diagnosed it, like there is a right thing to do. Dr. Frencher, what is the best thing that I can do? Like, I was like,
Yeah.
well, that best thing is going to be dependent on a lot of things that I need to learn about you.
Yep.
And that takes time. Like,
Yes.
and so that's the process for me from
Mhm.
a shared decision making perspective.
Yeah.
Like, and so it's a lot of listening, like,
Yeah.
and active listening in a way that we haven't really thought about doing that in medicine.